So good morning again. I'm going to introduce Bethea Dawson-Reese, and she's going to talk about testicular and prostate cancer today, March 2022. Bethea, it is all you.
All right, good morning, everyone. Like Dr. Baldwin said, I will be talking about testicular and prostate cancer today. After today's presentation, you guys will be able to discuss the prevalence in testicular cancer and prostate cancer, determine the types of screens men should get for these cancers and when they should begin, identify signs and symptoms of testicular and prostate cancers, and discuss treatment options for these cancers. So first we'll define testicular cancer. Of course, we know cancer is when the any type of cell continues to grow and forms that tumor. There you can see in the picture the tumor that is in the testicle or testes, which are part of the male reproductive system. They're located in the scrotum and produce sex hormones like testosterone and sperm. There are multiple types of testicular cancer due to there being a bunch of different cells that make up the testicles. But the most common type of testicular cancer comes from the germ cell tumor. So the prevalence of testicular cancer, of course, since it's found in the male reproductive system, only men are at risk, and that's all men. I saw that there, that range from children to adults. So the most common ethnicity is Caucasian men, who are about 4 to 5 times more likely than African Americans or Asians to be diagnosed. And the most common in males between 15 and 35 years old. And the average age of diagnosis is 33. It's not as prevalent as some other male reproductive cancers like the prostate cancer. About 1 in every 250 males will develop testicular cancer during their lifetime. So symptoms, a large or a lump or enlargement in either testicle, which it's ostracized because that is the most common symptom of how someone knows that they may, be concerned, similar to like how we find lumps in like breast for breast cancer diagnosis type thing. A feeling of heaviness in the scrotum, a dull ache in the abdomen and groin, a sudden collection of fluid in the scrotum, pain or discomfort in the testicle or the scrotum, enlargement or tenderness of the breasts, and back pain. That brings us to prostate cancer. That image there, where you can see it's kind of highlighted where the prostate is actually that little small, or this area here. You can't really tell, but it is the size of a walnut in most younger men. It's located by the rectum and just below the bladder. Here, there you can see what the size of a walnut would mean, like maybe 4 centimeters, but it can actually grow due to natural aging. So older men, it may be larger. The prostate makes fluid for the semen. So it's also part of the reproductive system. And there's multiple types of prostate cancer, but the most common is the adenocarcinoma. And that develops from gland cells, which are actually the cells that produce the fluid for semen. And there are other types of prostate cancer, but those are rare. So prostate cancer prevalence, of course, like we said before, with testicular cancer, all men are at risk for prostate cancer, most common cancer, along with skin cancer for men. Like I said, it's the most common, so more prevalent than the testicular cancer. About 13 out of 100 men will be diagnosed, but it's only deemed the cause of death for 2 to 3 out of the 100 men, they're more likely to die of other reasons before the prostate cancer, takes over. And then African Americans with a family history, like a first degree relative, are more likely to be diagnosed with prostate cancer. So symptoms vary for each person, and some may not even have symptoms at all. Difficulty urinating or starting urination, weak or interrupted flow of urine, frequent urination, especially at night, difficulty emptying the bladder completely, pain or burning during urination, blood in the urine or semen, pain in the back, hips, or pelvis that doesn't go away, and painful ejaculation. It's important to know that some of these symptoms are also symptoms for other conditions that men may have. So not to freak out or anything if your husband or you, I didn't know if I saw any males here, but anyone in your family have these symptoms, just to, go to the doctor and get further evaluation. So are there precancerous conditions? The short answer is yes, but it's not what we're most likely to see or think of. So benign prostatic hyperplasia, or BPH, is a common condition in men. It occurs when the prostate grows in size due to natural aging, and that cuts off the urethra and decreases urine flow. So there are medications to treat this. So things like tamsulosin or Flomax, Proscar, anything like that you may be familiar with or have heard of. Those are agents to treat this. BPH is not correlated to cancer at all, but there are conditions that are, which are the prostatic intraepithelial neoplasia and the proliferative inflammatory atrophy. So for PIN, there's low grade and high grade. Low grade is associated more with a risk increase, but high grade can be, research shows that it can be directly related to prostate cancer or PIA. And PIA, so that just shows multiple cell or small cell growth in the prostate, and it's seen in a biopsy. There's inflammation as well, and that can lead to prostate cancer, or I'm sorry, it can lead to high-grade PIN, which can lead to prostate cancer. So the link between the two, so prostate cancer and testicular, studies have shown that there may be a link between the two cancers. Men who have had testicular cancer may have a higher risk to develop prostate cancer later in life. Men with a history of testicular cancer had a 4.7% increased risk for all prostate cancer, and men previously diagnosed with testicular cancer were 5.2% more likely to get intermediate or high-risk prostate cancer. So cancer screening. Cancer screenings, these are done, prior to diagnosis, just once you become a certain age, similar to like colon cancer screenings or things like that need to be done just to make sure everything's okay. So for prostate cancer, there's prostate specific antigen test, which it measures the amount of the protein produced by the prostate, and that is found in semen and blood. The most likely source for the screen is a blood test, which has lower levels than semen, but it still can be a source for a screen to rule out anything. So the normal range is from 4 to 10. Those with an increase or greater than 10 level have an increased risk of developing prostate cancer. And normally, if the level is 2.5 or is less than 2.5, you would get another PSA done every 2 years. And then if it's greater than 2.5, you'll get an annual PSA. The digital rectal exam is just, as you may have heard, like when guys say they're going to the doctor to get their prostate checked, they bend over and the doctor just feels for any type of lump or bump or hardening on the prostate. And that is also a test that can be done for screening, but it's not as specific as the PSA. And as of right now, testicular cancer does not have a standard screening, but there's more research being done currently to help come up with screens that can be done. So who should be screened? Age 50 for men who are at average risk of prostate cancer and are expected to live at least 10 more years. Age 45 for men at a high risk of developing prostate cancer. That includes African Americans and men who have a first degree relative, like a father or brother, diagnosed with prostate cancer at an early age, which is considered to be younger than 65. And age 40 for men at an even higher risk, those with more than one first degree relative that have been diagnosed at an early age. Men greater than 70 usually don't need to be screened for prostate cancer for some reason. Of course, if they would like to and just want to check on things, then they can, but it's not a recommendation at this time. So benefits and risks. So some benefits from screening are early diagnosis and treatment. Although it's not a cancer that has a rapid growth or anything, some people would like to know and start treatment as early as they can so that they can go ahead and cure it and won't have to worry about it anymore. Some harms from screening are false positives and false negative results, in which those are kind of self-explanatory. So false positives would be like your PSA comes back elevated and you now you're causing some kind of anxiety type thing when you don't necessarily need to be thinking about that right now. Harm from diagnosis, so pain, blood and semen or ejaculation and infection due to the blood draws or anything like that. There's always risk for infection or blood getting into the area, and of course those are painful.
Bethea, you have a question in chat that's asked about the DRE. Is it still done? Because someone's husband had the blood test done and they didn't do the DRE.
It is still done. It can still be done, but it's not as as good of a test as the PSA. So some doctors may prefer not to do it and just go directly to the PSA. It's a more direct test that gives you a number that you can look at to determine what the next steps may be. And like the DRE, which you'll get that done, and then you'll have to do a PSA. It just makes more steps along the way.
Thank you.
Mm-hmm. And harm from treatment, so urinary incontinence. So a lot of men have trouble or have this problem once they have the prostatectomy, which is a removal of the prostate, erectile dysfunction. Men who have the surgery to remove the prostate and undergo radiation often have this as a side effect, the erectile dysfunction. And then bowel incontinence is also from the removal of the prostate as well, which will go into what the treatments are like now. So treatments. So active surveillance and watchful waiting, they kind of sound like what they are. Active surveillance is once you have like a diagnosis of prostate cancer, it's more so if it's not like an aggressive form, it grows slow, you just watch it. You get PSA levels drawn every 6 months just to make sure nothing's growing or increasing. And then if there are, then that's when you decide to treat the cancer. You can also treat symptoms at this point. As for watchful waiting, it's exactly what it sounds like. You just wait and watch, and there's no test done. You just continue life, and then maybe at your next annual appointment, get the PSAs and everything done again, and make another decision whether or not to continue with this or increase the treatment to a more effective treatment. So surgery is also an option, and there's different surgeries for each cancer. So for testicular cancer, there's the radical inguinal orchiectomy. So that is where they remove the testicles and surrounding lymph nodes or tissue that may be cancerous. And then there's other surgeries to remove lymph nodes as well if the cancer has progressed to other areas. For prostate cancer, there's a prostatectomy, which is the removal of the prostate, and then the radical prostatectomy is removal of the prostate and the surrounding tissues. So radiation is also an option. It's similar to an X-ray, as you can see kind of in the picture. They just use high energy rays to kill the cancer. There are two types of radiation therapy: external radiation therapy, which is used for testicular and prostate cancer, and internal, which is used only for prostate cancer. External is the one seen in the picture. Internal is they actually insert radiation beads directly to the prostate. It's associated with less side effects of the radiation, but may not completely kill everything. In chemotherapy, chemo is done in cycles, usually a treatment cycle followed by a resting period. Each cycle is maybe 3 to 4 weeks. And there's drugs like oral tablets and injectable drugs for treatment. The most common are listed there. And of course, for more aggressive treatment, you can also use 2 or more chemo drugs. And those are listed there too. And for, I included a general guide for men. It basically includes things to do for men in each decade: 20s, 30s, 40s, and 50s. It includes things like going to the doctor, getting all your levels checked, cholesterol, blood pressure, all of those things. The testicular exam, if you every self-exam every month, and then going to the doctor for prostate examinations once you reach those screening ages. And I just included it because I don't know if there are any men here, but for maybe your husband's brothers, sons, things like that, it'd be nice to have for them. And there. Here. And those are my references. And I'll be happy to answer any questions at this time.
Excellent. Does anybody have any questions for Bethea? You might be lucky, Bethea, and you might not have a single question.
Okay.
Because I don't see any in chat, or they're trying to figure out what they want to ask, or any of the number of things. Because the only question we had was that one, and I hope that you answered the question completely.